Conotruncal anomalies are a group of congenital heart defects characterized by the abnormal development of the embryonic cardiac outflow tracts, specifically the conus arteriosus infundibulum and the truncus arteriosus. These defects account for approximately 20 to 30% of all congenital heart disease. The primary mechanism involves the failure or malalignment of the conotruncal septum, which normally divides the common outflow tract into the aorta and pulmonary artery. This process is heavily dependent on the migration and differentiation of cardiac neural crest cells. Disruption in this migration often results in a spectrum of phenotypic expressions ranging from simple septal defects to complete transposition. Here are the major conotruncal defects. Tetralogy of Fallot, anterior malalignment of infundibular septum leading to a large ventricular septal defect, pulmonary stenosis, overriding aorta, and right ventricular hypertrophy. Transposition of great arteries, failure of the conotruncal septum to spiral, resulting in the aorta arising from the right ventricle and the pulmonary artery from left ventricle. Truncus arteriosus, failure of the conotruncal septum to form at all, resulting in a single large vessel supplying the systemic, pulmonary and coronary circulations. Double outlet right ventricle, DORV. Both great arteries arise entirely or predominantly from the right ventricle. Interrupted aortic arch type B, specifically associated with conotruncal defects, interruption between left common carotid and left subclavian arteries, often seen in DiGeorge syndrome. Pathophysiological patterns. The clinical presentation and hemodynamics of these anomalies are generally categorized by two main physiological states: cyanotic, that is decreased pulmonary blood flow, seen in tetralogy of Fallot and some forms of double outlet right ventricle. The obstruction to the right ventricular outflow tract causes a right to left shunt across the ventricular septal defect. Then there is the increased pulmonary blood flow or admixture group, seen in transposition of great arteries and truncus arteriosus. These conditions often present with early heart failure due to volume overload of the pulmonary circulation and systemic hypoxemia due to mixing. Genetic associations. A hallmark of conotruncal anomalies is their strong association with 22q11.2 deletion syndrome, DiGeorge or velocardiofacial syndrome. Up to 15 to 20% of patients with conotruncal defects may have this microdeletion, particularly those with truncus arteriosus, interrupted arch type B, tetralogy of Fallot with pulmonary atresia, or absent pulmonary valve. Clinical management considerations. Ductal dependency. Many of these lesions, like DTGA, interrupted aortic arch, require a patent ductus arteriosus for survival in the neonatal period, necessitating prostaglandin E1 infusion. Surgical strategy. Management ranges from palliative shunting like Blalock-Thomas Taussig shunt to definitive anatomical repairs like the arterial switch operation for transposition of great arteries or Rastli type repairs